afternoon to everybody joining us in person and those who are joining us virtually. It is my distinct honor to stand up here as the Grand Rounds Chair. This is our final Grand Rounds session that is a standalone event for this academic year. We will be having our last Grand Rounds as part of the Research Day that Dr. Dan Whitaker is hosting, so be aware and keep your eye open for emails on that. But I am thrilled today to be able to just introduce today's session and introduce Dr. Christine Stauber, who will be introducing our speaker for us. The Grand Round series started this year as an experiment, and I am honestly very thrilled to see how well it's gone, and the level of speakers that we've gotten, including today's, has just been such a joy as a chair to see of this committee to see happen. So thank you to all of those who've contributed and to make this possible. Thank you to the Grand Rounds Committee, who has worked alongside me to help identify speakers and get these invites out, as well as to all of the staff, including Amanda Norris, who's been our GRA and made sure that all of the students have gotten breakfast with our speakers, which has been a phenomenal opportunity. And of course, Marcus Cooper, for which none of this would happen. We would have no food or technology without him, so thank you, Marcus. As well as to Sam and Jordan, who've made sure that everybody knew that these were happening. So thank you to everybody, and thank you to Christine for identifying and inviting our speaker for today, and I'll let her introduce him.
Well, let's give Dr. Arias, or Professor Arias, another hand for doing all of this work today. I sincerely appreciate the opportunity to have these. It's one of the first times I feel like we've come together as faculty since, whether or not the pandemic has ended, I don't know, but you know, as we've started to feel more comfortable being around each other. So thank you, Jelaine. I'm excited for our speaker today. Dr. Guilherme Ribeiro is from the Federal University of Bahia at the School of Medicine. He has a medical degree, a master's degree in epidemiology, and a PhD. And he is currently a visiting professor at Emory, supported by Fulbright and a grant from the Brazilian federal government. And in the last 5 years, he's published at least 47 papers regarding his work on important urban health issues. And also, I would just like to say, as a fellow Fulbright alum, I'm really excited about the opportunity that Fulbright gives us, not only to understand research and questions that are pertinent globally, but also to have community and build cultural connections. And so I'm not going to say much more. I'm going to let Dr. Ribeiro come up, and we can have an opportunity to have some talks and questions later. So Dr. Ribeiro, welcome to the stage. We're looking forward to giving you a wonderful reception and learning about these important issues for your city and country. Thank you.
Hello, good afternoon, everyone. I'm really pleased to be here. I'd like to give a special thanks to Professor Arias and Professor Stauber for the invitation. And I feel very honored to be able to share with you some of the work that we have been doing in the city of Salvador in Brazil. So I'm going to talk today about endemic and emerging arbovirus, lessons from health surveillance and cohort studies in an urban epicenter in Brazil. I am an infectious disease epidemiologist, and the main focus of research in the last years has been investigating the outbreaks of arbovirus in the city of Salvador, and I'm going to share with you some of the finds. So, outline for the talk, I'm going to begin with a brief overview for those that are not very familiar with the arbovirus, talking about their vectors and their transmission cycle. I'm going to move on to bring some of our finds on the social and environmental conditions that favors arbovirus spread. I'm going to continue present some finds from dengue transmission in the city of Salvador, and I will finish highlighting the results of investigations related to the Zika and chikungunya emergence in the city of Salvador and in Brazil. And during my talk, I will be mainly focused on finds related to transmission dynamics and some of the health impact of this virus in the city. So to begin, an arbovirus is a virus transmitted by a mosquito. There are more than 150 arbovirus that are identified that can cause illness in humans. And the initial cycle of these arbovirus are based on the sylvatic environment between small mammalians, small animals, and vectors. And occasionally humans get inside the forest or in sylvatic environments, they can get infected. This is what happens, for example, with the yellow fever virus, where the infections currently are most transmitted in sylvatic environments. But some of these viruses adapted to be transmitted directly from humans to vectors and then back to humans. And this is what happened with both the dengue virus, the Zika virus, and the chikungunya virus. Just to highlight some of the most common clinical symptoms and signs related to these infections, typically they cause an acute febrile illness that have a self-limited course, but some of them may bring complications to the patients, such as bleeding and shocking in the case of a dengue virus infection. And as you may know, the Zika virus infection was related with congenital malformations and some neurological syndromes in adults, such as the Guillain-Barré syndrome. And the chikungunya virus infection can cause severe chronic joint pains that can last for many months, up to years. Several vectors can transmit arbovirus, but the two most important in the urban environment are those from the Aedes gender, the Aedes aegypti, and the Aedes albopictus, especially the Aedes aegypti. It's important to highlight that the cycle of these vectors needs a place where there is standing water, where they will put their eggs, and the immature forms will hatch from the eggs, and then will evolve to an adult form that will be able to transmit the virus. Then a bit about the city of Salvador, where the studies were performed. So Salvador is located in the northeast area of the country, on this orange region. Salvador is the capital of the capital of the state of Bahia, and it's located between the Atlantic Ocean and a bay, so it has a peninsula design, whereas the point of the peninsula is the Baja Lighthouse. So it's a beautiful city, it's a good place to visit, but it's also one of the cities most unequal in the country of Brazil. It's a large city with almost 3 million inhabitants, and it has a tropical weather with temperatures rarely going below 65 degrees Fahrenheit. So the conditions of the city is very propitious for propagation for arbovirus, since you have a tropical weather, a large population, and the inequality that produces an environmental context of lack of sanitation that favors the spread of the virus. So I'm going to begin present one of the finds of one of our investigations that was performed in the year of 2015. And this study initiated by a casual observation of one of my PhD students on that time, Igor Paplowski. Currently, he's a researcher here in the state of Minnesota. And at this time, he was doing entomological surveys in the city of Salvador and found, by curiosity, that there were water inside some of the storm drains in the city. And he began thinking about the possibility of this water service as a breeding site for mosquitoes. typically, we think that the water that is used for Aedes aegypti to reproduce is a clean water. And we don't believe the dogma is that the dogma is that dirty water was not good enough for the eggs to develop into the immature forms. But then we decided, here another PhD student, Raquel, who also finished his PhD, and Professor Uriel Caitron, who is my main collaborator at the Emory University. So we decided to plan a study to investigate whether the storm drains could be a good environment for reproduction of the vector. So we chose 4 areas in the city by convenience, areas that were close to our houses or close to the Oswaldo Cruz Foundation where I work. And we defined a path through some of the streets on the neighborhood and just walked through this path, identifying all the storm drains, mapping it, and looking for the presence of water, quantifying the amount of water in the storm drain by measuring it, and also doing mosquito aspirators, using Procopec aspirators, and collect water to check for the presence of immature forms of mosquitoes. And we did that between March and July of 2015. We did that in 122 storm drains in the total of the 4 areas. And we repeated the surveys in 2 different times because there were different possibility of accumulation of water if it was raining or not. So we repeated the survey, so we had more than 240 evaluations. These are the 4 areas on the city that we investigated. And we did find that in about half of the inspections, there was presence of water inside the storm drains. So the storm drains in Salvador were not built properly, and the water was being kept inside it. We also found both adults and immature forms of Aedes aegypti in 2 of the 4 areas that we surveyed, and we found in 1 of the 4 areas Aedes albopictus, both adults and the immature forms. The number of mosquitoes collected were quite impressive during this period, and we could conclude that it might be that these strains were having a role in the reproduction of the vector and contributing to the spread of the virus by the vectors in the city. So something that was interesting was that we shared our findings with the communities where we were doing the work, and one of the communities decided to intervene on the storm drains. So in this community, there were 52 storm drains, and they did a kind of simple structural modification of the storm drains by putting concrete in the bottom of it and raising the bottom to be in the level of the draining tube in a way that the water would not be standing inside the storm drain. And as researchers, we thought, oh, this is a good opportunity to evaluate what happened after this kind of intervention. So we went back to this community 1 year later, almost at the same time, and also performed 2 inspections in each of the storm drains in this community. And the findings were quite impressive. We saw that the amount of storm drains on this community that retained water largely reduced from more than 90% to less than 10%, but also the amount of water inside the storm drains that still maintained the water was much smaller, and the presence of adults and immature forms of the mosquitoes decreased substantially. So on this investigation, we could find that a kind of simple structural modification of the environment could help to reduce the propagation, the reproduction of the vector inside these kind of structures. I'm going to move to talk about another study that we initiated in Salvador in the year of 2009, and it is still ongoing. So it's almost 15 years of this study ongoing. We began that aiming to identify the frequency and the epidemiology of dengue transmission in one community of the city of Salvador. We established the one health unit of this community as an enhanced surveillance system where we invite patients seeking for health care due to fever to participate in the study, and those that consent, we collect blood samples at arrival, and then about 2 weeks later, to detect infections by arbovirus. Initially, we were just studying dengue, so we test the blood for serology for dengue, and we're using serology for dengue and also molecular tests such as RT-PCR. And since 2014, when chikungunya and the Zika virus began to circulate in the state of Salvador, we have also been testing the samples for this virus. I want to highlight that the community where we performed the study, it's located in the center of Salvador, but it's a kind of low-income area in the city of Salvador. It's highly dense, very overcrowded, and there is lack of sanitary infrastructure for many of the inhabitants of this area. So it has a propitious conditions for transmission of arbovirus by vectors. Just to highlight that this area in the city had a rapid and a disorderly urbanization process, and in about 40 years, it changed from an area of forest and vegetation to an area densely populated, and you can see that the health unit where you work is located here. These yellow boundaries surround one of the areas where we have been performing cohort studies on the neighborhood. So for the first period of the surveillance, where we just testing patients for dengue, between 2009 and 2013, we enrolled 6,700 participants, and about one in every 4 participants had some kind of laboratory evidence for a dengue virus infection. And you can see that we identified the case during every month of the surveillance with some periods of peaks, such as in 2010 and 2011. We identified that the 4 serotypes were circulating in the city of Salvador during this period. We had an epidemic of dengue 2 in 2010, and then in the year 2010, dengue 4 was introduced in Brazil, and we had a transition for another epidemic of dengue 4 in the following year. And based on the case that we identified during this surveillance, we mapped the households in the community, and we also used the data from the national census that is performed every 10 years in Brazil to estimate the incidence of cases by the census tracts on the region. So our surveillance at this time looked to enroll patients that lived in this area. We mapped the case and estimated the risk of getting a dengue fever disease for the different census tracts in the area. And we found that there was not a homogeneous distribution of the risk. There was a risk area closer to the health unit, which made sense because those that live closer to the health unit had easier of access to the unit, so we detected more cases for those that live closer. And we began trying to investigate if these incidents were correlated with the other environmental characteristics, social characteristics of the census tract. So we used the data from the census to characterize the population of each of the census tracts that formed this area. For example, we found that some census tracts had a higher proportion of the population being younger than 15 years of age, so it was a younger population. We had the information about sanitation, such as water supply, garbage collection, income of the population, and we did spatial analysis of correlation, and we found that some of them were associated with the risk of dengue being higher in this area, for example, the income level of the population. And even when we controlled it, we adjusted for the distance between the health unit to each census tract, this correlation remained, indicating that even in a low-income community, there was a social gradient influencing the risk of being a case of dengue. So together we had some evidence that social and environmental contexts, such as the presence of storm drains and the income level of the community, may be influencing the risk for arbovirus transmission. I'm going to move now I had already talk about the dengue and about these risk factors for disease. And then I'm going to move now to bring some of the finds related to the emergence of the Zika and chikungunya virus in the city of Salvador. So starting in 2015, the epidemiological scenario of arbovirus transmission in the city changed completely, because up to this time you only had circulation of dengue virus, and we began seeing cases with cases of patients going to health units complaining of red and itchy spots on their skin. We didn't know what was going on at this time, but the case continued to grow. And it was not only in the city of Salvador that this was happening. In other cities in the northeastern region of the country, patients were also seeking for health care due to this illness. So the city of Salvador, the epidemiological surveillance officer, with our help, established in the city a surveillance system so in order that the health units could report the cases that are being identified in the units. And in a short period of time, between February 2015 and June 2015, almost 15,000 cases were reported in the city. And the only criteria for reporting was to have a skin rash, the red spots with it, that didn't have another explanation of the cause for the disease. The incidence for this time, the attack rate, was almost 6 cases per 1,000 people. It's a huge incidence for a short period of time of a disease that we didn't know what was causing it. And it's important to show that other diseases that could cause rash, such as chikungunya and dengue, were not changing the report over this time. Dengue is in the blue bars, and you can see that didn't change much during this period, and the only 58 cases of chikungunya had been reported. And there was this huge increase, this spike of this new disease peaking in the mid of May. And on the letter A, on this figure, is the time when our collaborator, Professor Gubio Soares Campos, identified for the first time the Zika virus as the cause of this illness in 8 patients that lived in metropolitan Salvador. And very fast, on mid of June, the case had been identified, the virus had been identified already in 8 states of the country. These patients had as main clinical manifestations the presence of the rash, the red spots, and the itch. And other symptoms were not that common, such as fever and joint pain. And these are the hallmarks for chikungunya and dengue. So dengue that typically causes fevers, and chikungunya typically causes joint pain. So these patients didn't look like having dengue or chikungunya. Also, we tested the samples from 58 patients for dengue, Zika, and chikungunya, and we found the 3 viruses associated with some of the cases related to this outbreak. But altogether, we assumed that the Zika virus was the cause of the outbreak because of the 3 facts that first, okay, let's try again. So the clinical characteristics of the patients were not typical for dengue and chikungunya. So it was strange that this could be caused by this disease. Also, the epidemiological context of spreading of Zika throughout the northeast region of the country that was suggesting that what we were seeing was a Zika epidemic. And lastly, by the fact that at this time, our laboratory results for Zika virus diagnosis were not that good. So we could be missing many of the cases because of lack of sensitivity of our tests. So we were one of the first in Brazil to highlight the large Zika virus epidemics, and this was much time before the things that came out later that I'm gonna discuss with you. So at that time, Zika was seen as a benign illness. I remember that I was giving a class in the Federal University of Bahia, and during the break I went to the cafeteria to have some water, and the people were there on the line and say, oh, I think I have Zika because I'm eating. But people were going to the university and they were working. The disease was not much symptomatic in comparison to dengue, for example. We're afraid of the risk of Guillain-Barré syndrome because there was evidence that after an outbreak of Zika in French Polynesia, there was increase in the number of cases of Guillain-Barré syndrome. Guillain-Barré syndrome is a neurological illness. It's an autoimmune disease associated with infections or vaccination. It causes weakness that is progressively beginning on the legs and going up, and it can be so severe that it can cause death if the patient is not assisted. So we were aware of this risk, and we decided together with the Epidemiological Surveillance Office to review the medical data on hospitalizations by Guillain-Barré syndrome in Salvador, also because some colleagues were reporting that they were seeing cases of Guillain-Barré in the city, and we did find an increase in the number of cases of Guillain-Barré syndrome following the period of the Zika transmission in the city of Salvador that had the peak in mid of May, and we saw this increase in this period. Also in the same year of 2015, an increase in the number of newborns with neurological malformations was observed in the northeastern region of the country, and a possible association between Zika virus infection and congenital malformations were being raised at that time. So to also try to investigate this relation between these events, we began again, together with the Epidemiological Surveillance Office, analyzes the data on the report of case of that disease that we didn't know the cause at that time. We called it exanthematous illness that we attributed to be called to Zika, with the case that we identified of Guillain-Barré syndrome, the hospitalizations, and lastly with the children that were being reported having microcephaly after being born. So we used the temporal leaks and temporal analysis, temporal time lag analysis to do cross correlations between the epidemic curves of these three diseases and try to determine the strongest time of correlation between them. And we found that the Guillain-Barré syndrome cases spiked between 5 to 9 weeks after the peak of the Zika outbreak, suggests a potential relation between them, and also that the peak of the microcephaly cases occurred between 30 and 33 weeks after the peak of the Zika cases, corresponding to a period of potential infections occurring to the mothers about 7 to 8 months before the delivery. So there was an ecological evidence of possible relation between these events. We also compared the clinical characteristics of the mothers of these children between two groups, those the children had the diagnosis of a congenital malformation discarded after a neurological imaging exam by CT scanning or by ultrasonography, and those that had a confirmed find by the exam showing calcifications, showing ventriculomegaly, or any other kind of disorder on the neurological system. And when you compare these two groups, those that were confirmed and those that were excluded the diagnosis in relation to the mother's characteristics during pregnancy, we saw that it was much more common among the mothers of the confirmed cases to present symptoms during pregnancy of a disease compatible with a viral infection, such as fever, headache, skin rash, and usually these symptoms occurred during the first trimesters of the pregnancy. So these finds also provide some evidence of a relation between an infection during pregnancy and the risk of having a baby with malformation. So this was one of our initial investigations of this problem. Many other evidence came out with a better study designs, cohort studies, and case control studies that proved without doubt that there was a relation between the Zika virus infection and the congenital malformations. And I have to highlight the works that are performed by our colleagues in Fiocruz at Pernambuco, and also colleagues from Fiocruz at Rio de Janeiro that performed some of the most elegant work that provide evidence for this relation. However, at this time in the year of 2015, the Zika came as a surprise for us. What we were expecting was an epidemic of chikungunya. We were kind of being prepared to deal with chikungunya, and Zika came and it was a complete surprise for us. And why were we waiting for chikungunya to spread? First, because chikungunya virus was introduced in the Americas in the year of 2013 through the Caribbean region, and large outbreaks have happened in the Caribbean, and the virus had arrived at the north of Brazil in the city of Oiapoque, in the state of Amapá, coming from the Caribbean. And the Asian lineage of chikungunya was the one that was introduced to Amapá. And almost simultaneously, another lineage of the chikungunya virus, the East Central South Africa lineage, was introduced to the city of Feira de Santana in the state of Bahia. And this lineage was probably brought by a worker that was in Angola and came back to Feira de Santana. Feira de Santana is the second largest city in the state of Bahia, and is just 100 kilometers far from Salvador. So to go out of Salvador to come to Salvador by car, you have to cross Feira de Santana. So you were just expecting that a large epidemic would happen in the city. But we didn't saw it. As I showed, we had some cases confirmed when we were investigating the Zika outbreak, but there were only 58 cases reported in the city. We began questioning ourselves whether a chikungunya virus outbreak had not been recognized in the city because all the attention was directed to the Zika outbreak. The media, the people, everyone was talking about Zika, and maybe cases were not being correctly diagnosed, and they may have not seen a chikungunya outbreak that was being misclassified because of misclassification cases. So to determine whether an outbreak occurred in the city, we analyzed the data from patients that were tested for chikungunya virus infection using data from the state reference laboratory for the period between the end of 2014 and the beginning of 2016. This was also performed together with the epidemiological surveillance of the city of Salvador. So we have been closely working together for many years. So what we found, here on this figure you can see the number of patients that were tested for chikungunya on the blue bars, those that were positive for chikungunya on the red bars, and the black line shows the moving average of the proportion of positive patients, the proportion of positive samples for chikungunya. And you can see that the proportion of positivity began increasing in the beginning of 2015, then it goes down and it spikes in the middle of the year, after the middle of the year. Reach more than 65% of the samples positive for chikungunya at this time. What we concluded that, yes, we had an epidemic, an outbreak of chikungunya in the city, given the proportion of positive samples and the design of the curve of positive samples. And we had this find here that was strange, why the proportion of positives went down and they went back again. Anyone have an idea what is going on here? You can see that during this time, the number of samples, number of patients that are being tested were really huge compared to the other period. And this was because during this time you had the Zika outbreak. So there were thousands of cases of patients with rash and fever on the city. many patients had their samples being sent to test also for chikungunya, but were negative for chikungunya because they had Zika. That's why the proportion of positive went down during this period. And it's very likely that if you didn't have the Zika epidemic, the black line would go directly straight from the beginning of the year to the peak in the middle of the year. So we had some evidence that we did have an epidemic of chikungunya that was not recognized in the city. Let's go back to our enhanced surveillance study in the community of Pau de Lima. And now I'm going to bring the data when we began testing the samples also for Zika and chikungunya for this period, because we'd like to confirm if there was an outbreak of chikungunya occurring during the year of 2015. And here you can see the follow-up of the graph I had shown before between 2009 and 2013. Now it's going up to 2016. Here is just the results of RT-PCR for the patients. We had a period where our surveillance were not working between 2013 and 2014. Lack of funding, this happens. So we could not continue during this time. But we could see, we could detect the case of Zika in yellow and the case of chikungunya on blue during this period, showing that the occurrence of chikungunya were just after the detection of case of Zika in yellow, we had the case of chikungunya being detected. We also compared the clinical manifestations of the patients that we confirmed as having chikungunya, Zika, and dengue to check if we could use clinical signs and symptoms to differentiate the case during the acute phase of the illness. Although there are some differences, as you can see, for example, patients with chikungunya tend to arrive earlier with a median of 1 day of symptoms compared to patients with dengue, and the patients with chikungunya had the frequency of symptoms were higher, they were more symptomatic than others, and for example, arthralgia, joint pain was present in 95% of the patients. And conversely, Zika patients had more rash and the itching compared to the others. But although there are some differences, it's not that easy to differentiate because patients with Zika also had joint pain, patients with dengue also had rash. So clinically, it's not that easy to differentiate these patients. And we did review the medical charts of these patients to check what was the medical suspicions of the doctors when they saw this patient. They didn't have any laboratory testing that could make sure what was the diagnosis, but they could provide any suspicions for the disease. And as you can see, the doctors are not very good in correctly identifying what the patients had. So for those that had dengue, they thought that the patients had Zika. We had an epidemic of Zika. All the attention was for Zika. Only 90% were thought to have dengue. Among those that had the chikungunya, a more symptomatic disease, they didn't think it was chikungunya, and they didn't think it was Zika. They thought it was dengue, because dengue was more symptomatic than Zika. And for those that had Zika was the disease that they most correctly identified the patients, but even for those, it was only 23% that were correctly identified. So you also brought some data indicating that differentiate clinically these patients are not easy, and this has obvious implications for surveillance based on case reporting, which is based on symptoms. Reported as having one disease when they have another, and for clinical management, if you have to hydrate a patient with dengue and you think that he has Zika, you may lose the opportunity to do the correct thing. I'm going to move to another kind of study design that we used. We performed some cohort studies in the community of Pau de Lima, the same community where you have the surveillance established. To look for the dynamics of transmission of chikungunya when the virus was first introduced in the city. So we followed 652 subjects from the period before Zika virus introduction to 2016 to 17. How we did that? We had a cohort ongoing, and during the survey that we performed for the cohort in November 2016, February 2017, we consented the patients to test the samples that we had collected before to test them for chikungunya, because this cohort was not ongoing to test for chikungunya because we didn't know that chikungunya was going to be introduced in 2014. We did this going up to 2014 and retrospectively testing the samples. And the first evidence of patients of participants with antibodies against chikungunya appeared in the survey performed between August and November of 2015, indicating that after the mid of 2015 was when the virus was circulating in the city. So you had a large outbreak with almost 11% of the participants developing antibodies at this time. But after that, the transmission decreased its intensity, and you had an endemic transmission of the virus with a small number of cases and a low incidence after this first period of transmission. We also performed a larger cross-sectional survey between 2016 and 2017, enrolling more than 1,700 participants and testing for the presence of chikungunya antibodies. And we found again a prevalence of about 12%, very similar than you had here of 13%. And this was important because this indicated that about 1.5 years after the introduction of the virus, we still had more than 85% of the population that were susceptible to chikungunya, and further epidemics could come out. And that's what we saw in 2019 and 2020. We had other ongoing cohort that was begun in 2019, and the baseline study enrolled 606 participants, and at that time, 11% had antibodies against chikungunya. And in 2020, the year after, this increased to 55%. So about 50% of those that didn't have antibodies at the baseline developed the antibodies at the next follow-up. And then again, a slow transmission, low endemic transmission continued during the next years. What's important on this study that it's different from the other one is that during this time, we planned to make calls to the patients every 15 days, to the participants, every 15 days. So we are asking them about symptoms of acute chikungunya infection, such as fever, rash, and joint pain. And we found that among those that developed the infection during follow-up, 76% reported symptoms that were compatible with an acute chikungunya infection. So this provides some evidence that almost 80% of our cases, our infecting patients, had symptomatic illness, and only a minority might have had an asymptomatic or inapparent infection during follow-up. We also asked for the patients later on, for those that had symptoms when we detected the infection, if they continued with the joint pain for more than 90 days, which is the period that we use to consider a chronic chikungunya disease. And almost one third of them, 31%, reported the joint pain that lasted for more than 3 months. And 29% still had joint pain at the time of interview, 1.5 years after most of the infections have happened. In another study, similar to the other one that I just showed, but now with the patients that we identified as have chikungunya using the enhanced surveillance unit, we detected in 2015 265 cases of chikungunya, and we were able to talk by phone with them, with 57% of them, and we questioned them about maintenance of the symptoms, and again, we find very similar proportions of maintenance of joint pain for more than 3 months, 42%, and about 30% maintaining pain for more than 1 year after the acute infection. So this is kind of figures that show the impact of this disease for a large proportion of those that are infected and develop acute illness. At this time, we questioned, they also asked these patients, those that had long-lasting symptoms, about how this had impacted their daily life activities, and more than 90% complained of difficulties in simple activities like brushing the teeth, combing the hair, dressing. Almost 90% reported the limitation to walk, and even when you use the scale to measure mental distress, more than 60% had symptoms of mental distress. But it was uncommon for them to receive specialized care or even mental support. 10% has said that lost the job because of the disease. Now continuing with our surveillance study, I had shown this peak here in 2015 where we had Zika and chikungunya. You had a period without case, and then you had this other 2019-20 epidemic of chikungunya. But something called our attention in the middle of this period. We didn't see case of dengue during this period, and when you compare to the period between 2009 and 2013, we always had the RT-PCR positive case for dengue, and we begin asking what's going on here. We thought that our lab could not working properly, and we began repeating the test. We sent samples to other labs to be confirmed that they were really negative, and we were sure that the lab was working on fine. So we began bringing other possibilities of what had happened. And we were one of the first groups to raise the hypothesis that the Zika epidemics could have altered the transmission dynamics of dengue in the city of Salvador. To do that, we compared the proportion of patients that were positive for dengue before the Zika epidemics with the proportion that were positive for dengue after the Zika epidemics, using our surveillance in this health unit, and we saw a decrease from 25% to 3% of patients being positive. You can see on the black line the proportion of positive patients for dengue going down. And we used the data from the whole city of Salvador and found the same kind of reduction from 31% to 80%, and again, dengue was always about 20 to 30% of the patients that were tested for dengue being positive, and then it went down. So both the consistency and the strength of this finding supported our hypothesis that Zika infections could induce cross-protection, cross-immunity between from Zika to dengue. And we went on analyzing this pattern throughout South and Central America. So one of the PhD students, Vânia Mugabe, he's the student from Mozambique that I told you earlier in this morning. And he collected the data from the Pan American Health Organization that were freely available on the website. And we evaluated the trends on the incidence of dengue disease throughout 20 countries in South and Central America. And it was very clear, here are the 20 countries all together, it was very clear that there was a trend of increasing the incidence of dengue, and that after 2016, it went down. Early on in 2019, it peaked again. We saw that for the countries together, but we also saw the same trend in most of the countries when you look for the pattern isolated. So you can see in Mexico, Nicaragua, Bolivia, Brazil, Colombia, many of the countries had the same kind of pattern of a trend in increasing dengue, and then after the Zika epidemics, the occurrence of dengue went down and peaked again in 2019. Example, Mexico, Nicaragua, and Colombia and Brazil. So these findings also supported the idea that the Zika epidemics changed the pattern of the transmission of dengue, probably by cross-immunity. And if there is really a cross-immunity, this is not a long-term immunity, and it should last only for about 2 years. And the last finding that I want to show is that we also find evidence on the other direction, that prior dengue infection could also alter the risk of having Zika. So we had a cohort ongoing in Pau da Lima that had samples collected before and after the Zika epidemics, and we identified that 73% of the cohort had developed the antibodies against Zika between the beginning of 2015 and the end of 2015. So you can imagine how huge was this spread of Zika in Brazil and in a city like Salvador when you find that 73% of the participants developed the antibodies in a short period of time. And the distribution of the positivity was heterogeneous, with certain areas going as high as 83%. But the important find was that individuals that had high titers of dengue antibodies before developing Zika infection had a decreased risk of getting Zika infection. The higher the antibody titers against dengue, the lower the risk of developing antibodies against Zika, indicating a protection from a recent dengue virus infection to acquiring Zika. And also we found that those with high titers of dengue antibodies prior to the Zika outbreak had a 47% reduction in the odds of developing symptomatic Zika when they had the infection. So a prior dengue infection protects not only of Zika infection, but also of Zika disease. So to finish, I want to highlight some of the key messages from the investigations that we had performed in Salvador, some of them. So first, that we found social and environmental conditions that are related with sanitation and neighborhoods incomes level that may influence the risk of arbovirus transmission. Second, we saw in the year of 2015 the co-emergence of Zika and chikungunya virus, which joined the dengue virus as a cause of acute febrile illness, bringing increasing the challenge of diagnosis, surveillance, and management of the patients. Third, the impact of this new virus in Brazil were enormous, with both an immediate impact for the acute cases that were overcrowded the health units due to their acute illness, but also for the long-term health consequences such as birth defects and chronic joint pain. As with COVID-19, a rapid response was initiated in the country in the areas of research, surveillance, and medical care. And we had some success, such as establishing the causal association between Zika virus infection and congenital malformations. But there is much to progress in order we can reduce transmission and provide the proper health care for the complications of the disease. And finally, the cross-immune response between flavivirus, dengue and Zika that are from the same family, has implications for surveillance, for immunopathogenic studies, and for vaccine development and evaluation. So I want to finish. Thank you for your attention, and acknowledge that this work was done with several students and collaborators of different institutions, and all of them were really important in making us able to develop this work. Thank you for your attention.
Well, I will start. It seems to me that rapid urban growth, especially poorly planned, has contributed to arboviral disease transmission. And I wonder if you could speak at all to whether or not that pattern is changing in Salvador, or if it continues in the same way.
So I don't think it's changing. We had a period in the mid-19th century, 20th century when many people moved from the countryside to the large and urban areas in Brazil, not only to Salvador. And this was a rapid movement, and the cities was not prepared to receive all these people. So informal settlements began to increase in the cities, and the sanitation didn't came together. So not only sanitation, but also other kind of infrastructure for the population, like schools and health facilities and the recreational areas. So we had a large proportion of the population of the city of Salvador that lives in informal settlements, and for sure that this environment contributes to the transmission of arbovirus because it facilitates the reproduction of the vector. People have to accumulate water in the house because they don't have a regular supply of water. You don't have a regular collection of trash, trash that keep waiting for be collected as place to the mosquito reproduction. So I think it's for sure an important point, and many times not really the focus of the vector control programs that try to focus on the population doing their part, on keeping the water correctly, but how you can do that if there is not water arriving for you regularly. So we need more investment from the governments for the sanitation.
You'd mentioned going back to blood samples, I believe, that were taken from previous years and tested for diseases, and then going back and retesting it for chikungunya. How were those stored? And then how do you end up going back and reanalyzing those?
So as I said, we first reconsented the participants to have their samples that were stored to be tested for something that was not initially thought about to be tested. And the samples are stored in freezers at -20 or -80, depending on the kind of sample. And we use the regular ELISA test, serological test, to perform the testing for chikungunya. For Zika, because of the cross reaction between Zika and dengue, it's not that easy to discriminate the two infections. You had to use the other kinds of more sophisticated tests, sometimes neutralization tests or specific tests. And even that you had to calibrate our estimates based on sensitivities and specificities of these tests.
We're going to end it there and say thank you so much. We do have a reception right out here, so if you have some questions you would like to talk about with our speaker, we'll be sort of hanging out in this area right here. So please join us for the reception for a little bit.
Thank you.